Okay, so we're going to be going over the hepatic system and like kidneys. There's going to be a lot more practice questions and actual content because I feel like this is one of like the big heavy hitters on the HESI as well as the exam. So, okay. So we'll start out with AKI, so acute kidney injury. The signs, like the labs that you're going to see for acute kidney injury, is a high BUN and creatinine. Remember that if only the BUN is high, it's most likely indicating dehydration and not necessarily a kidney injury. You're also going to see high potassium with or without oliguria, so not peeing as much. AKIs are potentially reversible, so you want to catch them as soon as possible and treat them. Infection is the leading cause of disease or cause of death for those with AKIs. Signs and symptoms could be malaise, so being tired, flake tenderness in the, I think it's crossover area, decreased urine output, or it's a dark amber color, weight gain, so you're holding onto that extra fluid, not filtering it through, jugular venous distension, ascites, crackles, periorbital edema, anemia, high CVP, PAWP, low consciousness changes from the electrolyte imbalance, EKG changes from hyperkalemia. So essentially, you're seeing all these fluid overload symptoms as well as your electrolyte imbalance symptoms. There can be three different causes like pre-renal, intrarenal, and post-renal. Pre-renal is something that happens with like blood flow. So hypovolemia, myocardial infarction, shock, embolism, or anything decreasing your cardiac output. So that's your pre-renal causes. Intrarenal causes, most common is acute tubular necrosis. So some part is like dying of the kidney. Nephrotoxic drugs like vancomycin, contrast media from CT scans, hemolytic reaction, so blood incompatibility, or lupus. Post-renal causes, so something's blocking the urine from, or like the stuff from coming out of the kidneys. So mechanical obstruction, like benign prostatic hyperplasia, prostate cancer, calculi, so kidney stones, trauma, or an extrarenal tumor. Okay. Oh, sorry. Also can be caused by sepsis, right? Because we know with MONS, AKI goes along with that. Rifle classification, rifle is an acronym that stands for risk, injury, failure, loss, and stage disease. This is how they progress. So at first they just have a risk for an AKI, then they actually have an AKI, then their kidneys start to fail, they lose function, and then they're in end stage kidney failure. GFR is one of the most important indicators of kidney function, as well as creatinine urine output. We want GFR to be above 60. There's different phases of an AKI. There's oliguric. This occurs from about 8 to 15 days. Urine output is less than 400 milliliters per day. They have hyperkalemia because they're retaining all of these electrolytes. Hyponatremia because they're retaining potassium and sodium switch places through the pump, sodium potassium pump in the cells, as well as they're overloaded with fluid, so it's diluting the potassium. Hypocalcemia, high BUN and creatinine, metabolic acidosis, anemia, and platelet abnormalities. Then they move into the diuretic stage where they pee about 1 to 5 liters per day. They still have a high BUN and creatinine, but their electrolytes are now being wasted because they're peeing them out, so they're all low. So watch for hypovolemia and EKG changes from now we're letting go of all of that potassium so that EKG can change again. Then you get into the recovery phase where the GFR increases, so we're having better filtration, BUN and creatinine finally decrease. And then we want to make sure we're doing strict INOs to prevent progression to chronic kidney disease. And that's the case for all of these stages. The stuff that goes in should be coming out. We should have an equal balance, okay? So then we move to chronic kidney disease. This is irreversible, whereas acute kidney injury was reversible, potentially. This is irreversible loss of kidney function. Many cases are from diabetes or hypertension. So you want to educate hypertension diabetic patients about controlling their disease so it doesn't turn into chronic kidney disease. Signs and symptoms could be uremia, so uric acid in the blood, fatigue, lethargy, pruritus, so itchiness, hypertension, hyperglycemia, hyperinsulinemia, dyslipidemia, So they have cholesterol issues, hyperkalemia, hyponatremia, acidosis, anemia. Um, so decreased EPO. EPO comes from the liver, which causes production of red blood cells. Jaundice, again, from liver being related to this. Peripheral neuropathy, personality changes, depression, hyperphosphatemia. Also, so phosphate, remember, and calcium are like enemies. So if there's high phosphate, we have low calcium. So when we have low calcium, we can see trousseau's or Chavostex. Trousseau's is the blood pressure squeezes and they have a carpal tunnel spasm, and then Chavostex is the, I think that's right. Anyways, we talked about it in a different video. Common cause of death is cardiovascular disease for chronic kidney disease. This is from uncontrolled blood pressure and imbalances in the body. Because if you can remember, the kidney is in charge of also regulating blood pressure. And I think we'll talk about that a little bit later. For CKD, GFR again is the best indicator, and then creatinine and bun ratios. You want to make sure you're taking daily weights on these patients to see how much fluid they're retaining. They're going to need dialysis because most likely their GFR is going to be less than 15, which is the indicator for dialysis. EPO and iron replacements, statins to control that cholesterol. Remember, with statins, we want to be watching for muscle breakdown and rhabdomyolysis. They're following a renal diet, so low sodium, low phosphorus, low protein, low potassium, and low calcium. So a lot of phosphorus comes in our dairy products as well as calcium, so most dairy products are avoided. Their fluid intake for the day is determined from their 24-hour output from the day previous, plus 600 milliliters. However, so this is for dialysis patients. If they're having peritoneal dialysis, which we'll talk about the difference soon, they have unrestricted fluid intake, essentially, if their blood pressure and weight are controlled. But just remember that 24-hour output plus 600 mils for their total intake they can have for the day. Urine output tells us how well the kidneys are perfused. So if it's a question talking about perfusion of the kidneys and the function of the kidneys, end stage organ, whatever, we're looking at urine output. Okay, so this should look familiar. 60 to 120 is normal. This yellow is like the warning signs, right? But less than 15, they're going to be on dialysis. So stage 1, 90 plus, they're usually asymptomatic. We want to make sure we, like stage 2, 60 to 89, need to control their hypertension and diabetes to slow the progression of chronic kidney disease. 30 to 59, you'll start to see symptoms. 15 to 29, stage 4, prepare for replacement therapy, and under 15, need dialysis to survive. Okay, so this is dialysis. So we have hemodialysis. They're going to have a fistula put in where they connect an artery and a vein through a graft. No IV or blood pressure in that arm, contraindicated. To make sure that that fistula is patent, you can feel a thrill and hear a bruit with the bell of your stethoscope. Just so you know, when that, like the dialysis port or like they access the fistula, arterial blood leaves and gets dialysized or whatever, and the waste is removed and the blood is returned through the vein, and that's why that connection is there. We're going to need it 3 days a week, 4 hours each of those days. Some risk can be hypotension, muscle cramps, blood loss, disequilibrium syndrome. So basically they remove too much too quickly and they get hypotension and cerebral edema. When this happens, you lower the head, raise the feet, and possibly give them anticonvulsants, depending on what the provider says. They have an air embolism from this, stop the dialysis, give oxygen, turn them on their left side, and Trendelenburg head down. So those are some complications with hemodialysis. Okay, peritoneal dialysis, there's a catheter inserted into the peritoneal space in the abdomen. There's dialysate, about 2 liters, that flows in through gravity. And then that fluid that's sitting in that peritoneal space interacts with the capillaries that are in the bowels and stuff and pulls out the waste from those capillaries into that fluid. And then that fluid drains out through gravity to an empty bag down below. After it's sat for a little bit. And so inflow is when it fills, dwell time, equilibration is about 2 to 3 hours. And then drain, the outflow is called effluent. It should be slightly yellow and clear. There's a very high risk for infection. And so if they have distension, their abdomen's rigid, they're having signs and symptoms of fever, like or infection. You can suspect peritonitis. Pain, pneumonia, and bronchitis also possible because of the abdominal like, closeness to the lungs. Okay. There is a risk of high blood sugar with this because a lot of times the dialysate has sugar in it because of osmolarity. It needs to have like lots of solvents in it or solutes so that it pulls it out through osmosis, pulls the stuff out. So, or like pulls the water with the waste in it to the dialysate to create equal concentrations. Then we have continual renal replacement therapy. This will often happen if your patient is intubated in the ICU to protect their kidneys. They're going to do the CRRT. There's a double lumen catheter in the femoral jugular or subclavian vein, and it's just constantly helping the kidneys function. Continuous bladder irrigation. If there is a Foley in, like a multi-lumen Foley, one port can be used for irrigation. A lot of times this is used after BPH repair, prostate cancer removal. Just make sure you're using the correct port. We don't want to be like trying to irrigate through the balloon port that like eventually pops the balloon, you know. And so this continual bladder irrigation can decrease the bleeding from like a TURP procedure. If they get a transplant of their kidneys, it can be from a live or deceased donor because you only technically need one kidney to survive. Two is for best function. But right after the transplant, they're going to be like polyuria. There's going to be tons of urine coming out. There's a pretty high risk of rejection, so they're going to be on immunosuppressants. Remember, acute rejection occurs within 24 hours, and they'll need to have that kidney removed, unfortunately. Because of the immunosuppressants, they have a high risk of infection. So the leading cause of death after transplant is cardiovascular disease. So you want to make sure to be monitoring their heart status and making sure they're eating healthy and protecting their heart. Hyperacute rejection, about 48 hours, 24 to 48 hours, immediate removal of organ. You'll see a high temp, high blood pressure, high pain. Okay. Acute 1 week to 3 months, 6 months-ish. Increase immunosuppressants, and then chronic, you'll have to eventually replace the organ, just treat the symptoms. So 6+ months. Okay, so this is a fistula, an artery, and a vein grafted together, and that's how they're going to access right here is, yeah, one part is going to be the artery, the blood's flowing out, and then the blood's flowing in through a vein. Peritoneal dialysis, we have the dialysate solution here that inflows, dwells in the peritoneal cavity and interacts with the capillaries, pulls the water and waste out of the GI system, and then through gravity outflows into this bag right here. People can learn to do this at home. And this, I think, is the continual renal replacement system. This is way more complicated than I can even explain, but if you want to just walk yourself through it and understand what's happening. But okay. This is bladder irrigation. This is continuous bladder irrigation, meaning instead of you going in and like flushing with a syringe, this is they just hang the irrigation solution, and it's a triple lumen catheter, and they've connected it to the correct port, and it is going and it is flushing, and then it drains like normal into the catheter drainage bag. Okay. As a review, incontinence, it can be caused by stress. So a sneeze, cough, laugh. This often happens after like giving birth. To help this, you can do Kegels or pelvic floor strengthening exercises. Urge incontinence can be fixed with bladder training. Functional incontinence is because they can't like unbutton their pants or walk to get to the bathroom. So you're going to help set a schedule to help them to the bathroom. About like every 2 hours, you ask if they need to go, and help them know how to push their button if they need to go. Kidney stones, one common sign of kidney stones is they won't be able to sit still. They're very restless, and that's because pain is intense with kidney stones. So pain is a priority. Treat their pain to get them comfortable. Treatment is lithotripsy, so they're going to use shock waves to break apart those stones. After that therapy, you need to instruct them to strain all of their urine and collect all the stones, and those stones will be tested for its contents to determine what caused it. The cause of stones can be high calcium. So a 24-hour urine collection, you have them urinate and then you start the time right after they urinate. So you don't include that first urination as part of your 24-hour collection. You're going to keep this 24-hour collection on ice to keep the specimen viable. Next thing is like catheters with your urinary catheters because there's such a high risk of infection. We're always assessing for when we can remove that urinary catheter when there's not needed anymore. A TURP, trans urethral resection of the prostate. You're gonna get resection and then OSIN meds, so like tamsulosin for the BPH. Catheter, like we just talked about, can be used to flush clots out. So if you're seeing clots in like blood, you can increase the rate of irrigation to help decrease that bleeding. Just as a reminder, some terms, anuria is an emergency that's less than 50 to 100 mils of urine out in 24 hours. Oliguria is about more than 100 but less than 500 out in 24 hours. Polyuria is 2,500 plus in 24 hours. Acute post-streptococcal glomerular nephritis, that is a mouthful, occurs about 1 to 2 weeks after a strep infection. You're gonna get hematuria, so like a smoky urine color because there's blood in it. With oliguria, so less urine, there's gonna be proteins, red blood cells, and white blood cells in it. Their blood pressure is usually gonna be pretty high, but you guys go over this more in maternal. So then we also have nephrotic syndrome, permeable to plasma proteins. So proteins are not usually filtered through. Proteins are used in our bodies. And so albumin, which is the protein responsible for blood pressures, like osmotic pressure, um, decreases. And so that causes, so there's going to be a lot of albumin in the urine and not a lot in the blood. And this causes edema because the fluid is no longer being pulled into the vessels, but leaking into the interstitial tissue. So you'll see like ascites, hypercoagulable blood, hypertension, hyperlipidemia, stuff like that. Okay. So this is a good visual to remember nephritic syndrome and nephrotic syndrome. So you guys can go over that on your own. Okay, so hepatitis A and B, there is a vaccine available for those two. C, there's no vaccine. Usually transmitted percutaneously. So ask them when their last blood transfusion was. Usually, if it was before the 80s, they have a risk of contamination with hepatitis C. The acute phase, you'll feel malaise, jaundice, anorexia, nausea, vomiting, fever, myalgia, so muscle achiness, right upper quadrant discomfort, which is where your liver sits, hepatosplenomegaly, so large spleen and liver, and swollen lymph nodes. This can lead to liver failure, cirrhosis. Cirrhosis is irreversible liver failure. Hepatic disorders can include drug-induced liver injury, most common being Tylenol. Remember that the antidote for Tylenol is acetylcysteine sulfate. Remember that. Vancomycin can also cause liver injury. Biliary cirrhosis or sclerosing cholangitis, angitis. Basically the same concept. The ducts become tight or hardened and doesn't allow passage of bile. Non-alcoholic fatty liver disease. This is not caused by alcohol, as the name suggests, but caused by metabolic syndrome. So that high blood pressure, high cholesterol, high sugars, diabetes, large trunk compared to the rest of the body. Cirrhosis is irreversible liver damage, destruction of parenchymal cells, the cells that make up the liver. Can be caused by viral hepatitis or alcohol is a very common cause. You'll have jaundice, fatigue, hepatosplenomegaly, spider angiomas, blood problems, endocrine problems, ascites, peripheral neuropathy. Also going to have feta hepaticus, so a fruity or musty breath smell. Pulmonary erythema, clotting because of the increased vitamin K. So you're going to have a long PT time, or sorry, short PT time because your blood clots really fast. There's going to be a difference in medication metabolism because liver metabolizes the medications. Behavior change because of increased ammonia. Ammonia goes to the brain, can cause encephalopathy. To decrease the ammonia, you use lactulose, which causes massive amounts of diarrhea, which takes the ammonia with it. To test their mental status when they have cirrhosis, you can ask them to write their name. down and see if they're able to do it. Portal hypertension can happen with cirrhosis from varices. This can cause bloody vomit, so like that coffee ground emesis, ascites, hepatic encephalopathy. So if they have portal hypertension and varices with bloody vomit, obviously that's a reportable incident to the provider, but they're going to need a balloon tamponade or sclerotherapy to stop the varices from bleeding because they can bleed out from that. Alcoholic liver disease causes jaundice, longer clotting times, and ascites. Okay, so the best way to help them is to help them stop drinking. Okay, acute pancreatitis. Feel like I've seen this come up a lot, but this is when pancreatic enzymes spills into surrounding pancreas, causing autodigestion and severe pain. So pain is another priority here for pancreatitis. You're going to see the bluish discoloration of the flank. It's a gray Turner sign. Make sure you report if you see this. Or you're going to see that same bluish discoloration at the periumbilical area, which is known as the colon sign. You're going to have a high serum amylase, respiratory issues, because the next place all this enzyme and stuff is going to go is respiratory. Trypsin increases PT and plasminogen, so you're going to have more clots and DIC eventually. To treat, it's NPO. They're going to need NG tube suction to get all those enzymes out. Fetal position or tripod helps relieve that pain. You're going to monitor for hypocalcemia because that is 40 to 75% of people with acute pancreatitis experience hypocalcemia. So look for the Chavostex and Trousseau's signs. Another thing with acute pancreatitis, you're going to want to assess what they eat. And so assess what they eat, make sure they're not like eating tons of fatty foods, caffeine, stuff like that. So jumping into practice questions. Okay, so they have esophageal varices at risk for hemorrhagic shock. Which of the following is a sign of potential hypovolemia? The answer is C, hypotension. So it would be tachycardia, not bradycardia. It would be cool skin for late shock. And then oliguria instead of polyuria because the kidneys are not being well perfused at this point. Okay. So cirrhosis, irreversible liver damage. They have deficient vitamin K absorption. What's that going to cause? It's going to cause purpura and petechiae because it disrupts, so they're not clotting like normal. So because low vitamin K means they're not producing prothrombin, which is a clotting factor, means they're not clotting very well. That's why you're going to see purpura and petechiae because of the leaky blood. Okay. Okay, so spironolactone or aldactone for someone with fluid retention, which indicates the drug is producing a therapeutic effect. And so fluid retention means they gained with chronic kidney disease or cirrhosis or anything like that, we're weighing the patient daily because they have a tendency to hold on to fluid. And if we want to get that fluid off, the other thing that you're going to measure again is their weight. And so loss of 2.2 pounds or 1 kilogram in 24 hours indicates that they are losing that water retention. Okay. So just remember that 2.2 pounds or 1 kilogram is a loss of 1 liter of fluid. Okay. Okay, so they have cirrhosis, they develop portal hypertension. What medication do they go to prescribe? The first one is Cantrex. This is an antibiotic. It's a mycin. Cyclosporin, Sand Immune is post-transplant. It's like a immunosuppressant. Spironolactone is a diuretic for the blood pressure. Portal hypertension, we want a blood pressure med, right? So that's the answer. D, lactulose is for hepatic encephalopathy. So if they had said something in there that would have indicated they had that, we can say the answer, but they gave us a hint. It says portal hypertension. We want a diuretic to decrease blood pressure. Okay. So this is the metabolism of ammonia. You can go over this, but basically what you need to know is that ammonia gets released when liver is damaged. It becomes neurotoxic, causes brain edema, and possibly death. So we want to be, yeah, it just backs up instead of getting wasted, which is dangerous. Okay. They have severe ascites. They find that his indwelling urinary catheter is too full to store more urine. They empty more than 2,000 mils, so 2 liters from the collection bag. 1 hour later, she finds the collection bag full again. She notifies the physician, who suspects a bladder rupture is allowing the drainage of peritoneal fluid. So it's not just urine in there, it's peritoneal fluid. This physician orders a urinalysis to be obtained immediately. Presence of which substance is considered abnormal? The answer is A, albumin. There should not be albumin in the urine. So this means stuff is not filtering well, proteins are not being excreted because they're precious to the body. Body does not want to lose proteins. Creatinine is normal to find in the urine. You should be finding creatinine. And then urobilinogen is the like bilirubin form for urine to create that yellow color. And then chloride is normal to find in the urine. Okay. Have cirrhosis. Noted that client's abdomen is enlarged. What should the nurse consider? The answer is D, measure abdominal girth according to a set routine. So we want to like notify like if the abdomen has gotten really enlarged, maybe ascites or peritonitis or something like that. So, okay. Caring for a patient whose liver has required the insertion of a percutaneous biliary drainage system. It reveals dark green fluid, and the answer, what's their response to this? And the answer is document it, because bile should be dark greenish in color. So the rest of it is not really indicated. The rest of the answers. Okay, triage in the ER assessing a patient with general malaise. They have jaundice and increased abdominal girth. Which question best addresses the possible etiology or cause of this patient's presentation? The answer is A, how many alcoholic drinks do you typically consume in a week? Because they're presenting signs of cirrhosis. Okay. Hepatic encephalopathy, they notice that the patient has a flapping tremor of the hands, which is asterixis. So answer is A. B, constructional apraxia. I didn't know what this was, so I looked it up. It means you cannot reproduce a simple figure, like if you draw the letter or number 8 and ask them to redo it, they couldn't. Fetter hepaticus is a sweet fecal order to the breath. And then palmar erythema is what it sounds like. It's red palms. Okay. Client with glomerulonephritis, so kidney infection from strep, is at risk for developing acute renal failure. The nurse monitors the client for which sign of this complication. And it's hypertension. So kidneys help control blood pressure because of that angiotensin 2 system. Okay, like renin and all that stuff. Okay, so they just got an intravenous pyelogram. Determined is what's important in the post-procedure of this client. The answer is A, increased fluids, because we're trying to get rid of that dye used in that pyelogram. Okay. Okay, they have cystitis. What beverage needs to be eliminated to minimize the recurrence of cystitis? Tea. So we don't want caffeine or alcohol for cystitis. Fruit juice, water, lemonade, they're all a little bit acidic, except water is just good to drink anyways. But A and D are a little acidic, which can help the bladder, because cyst means bladder. Okay. Prevent recurrence of cystitis. The client needs further instructions, so which answer choice is wrong if they verbalize what? A, take bubble baths for more effective hygiene. Bubble baths are not great for infection or really just in general. B, wear underwear of cotton. Great. Breathability. C, drink water and void after intercourse. Great. Avoid wearing pantyhose while wearing the socks. Great. We don't want all these layers causing lots of sweat. Okay. Nephrotic syndrome, nurse documents what important parameter needs to be assessed daily. The answer is B, weight because of edema. Okay, because that albumin loss is going to cause fluid retention and edema. Okay, so they just started hemodialysis. They haven't tolerated the procedure optimally if they experience what, representing disequilibrium syndrome. The answer is B, headache, deteriorating level of consciousness, and seizures. This is what's occurring because of the rapid removal of solutes from the body during hemodialysis. The blood-brain barrier interferes with equally efficient removal of waste from the brain tissue. So as a result, like water goes into the cerebral cells because of the osmotic gradient. It causes brain swelling and the onset of all of these symptoms. So it occurs to like patients who are new to dialysis. It's prevented by dialysizing for shorter periods of time at reduced flow rates. So just remember disequilibrium syndrome dealing with the brain, you're going to have brain symptoms. So headache, level of consciousness, seizure. Okay. This is that calculation. We're going to do, they excreted 300 mils of urine in addition to 100 mils of other losses. So their total amount of losses was 400. And then you add 600 allotted fluid. So their next allotted intake for the next 24 hours is 1,000 mils. So does it apply for risks for CKD? Older African Americans, also Native Americans at a high risk, older than 60 years, those with hypertension and type 2 diabetes. Okay, and that is it for the hepatic system and renal systems.